we just have people living in this alternate reality, and that's the thing that we can't break through.
Welcome back to Inside Science Conversations. I'm your host, Chris Gorski. I'm a senior editor at Inside Science, which is published by the American Institute of Physics. This is a show about the human side of scientists, what makes them tick, what are they interested in, and how did they get to where they are. If you haven't watched episode 1, please do check it out. Phil Skiba told me about his life and career from would-be astronaut to triathlete, trainer and coach to working with Eliud Kipchoge on the team that was trying to help him run a 2-hour marathon. And to get there, he just started with a little bit of math. That's what he said. But also, more recently, he's been working with patients who have or had the coronavirus at the front lines, with athletes who come into the clinic saying, I can't run as fast as I used to. What's going on? And so he's trying to help understand and address that problem. We're talking in December, the Omicron variant is coming through the United States, infecting so many people in other countries, and it's coming, it's already here, right? Yeah, I'm just curious about what your experience in medicine has been, from March or maybe a bit earlier of 2020 and on.
I saw this coming relatively early on. I've always had this interest in infectious disease. When I left my PhD in microbiology, I was working on trypanosomiasis, sleeping sickness, Chagas disease, things like that. So I've always had an interest in kind of world health. And when the first news came out of China that there was this thing, brewing in January, I immediately thought of SARS, and the way and MERS even, in the 2000s, and we were able to stop those relatively easily. Even when we had some Ebola coming into the country, we were able to stop that. But it was relatively clear, relatively quickly, that this was not going to be stopped. That there was a political element to this to try to minimize the risk, and I kind of knew we were in trouble as things were building in Italy. And my colleagues there are telling me this horror show that they're seeing. I started kind of going to the hospital leadership. Some of my colleagues, the guys, like, there's something bad coming, and we got to be ready. And people were saying to me, oh, come on, Skiba, you're being Chicken Little. The sky isn't falling. It's not going to be that big a deal. It's cold, whatever. And then all the deaths started in Europe, and it was like, okay, this is not a cold. And then New York started getting demolished, and then a week later we were shut down in Chicago. And from my perspective, I'm third or fourth generation volunteer firefighter. Before I went to medical school, that's what I did in my hometown in New York. The way I was raised was, when something's on fire, you run towards it, not away from it. And so I volunteered to work the front line. We opened up these MASH tents behind the hospital because we were trying to keep the hospital from being overrun. And so I spent the first few months of the pandemic, working on the front line, which was scary as hell, to see it face to face. And all that's between you and it are a pair of goggles and this N95 mask, and every now and then you almost felt like you were kind of standing outside yourself watching it, because, for example, right, you don't want to contaminate, your house. The way, like, for example, when you look at something like Ebola, the way most people get it, the way most doctors get it, is when they are taking off their protective equipment, because they end up contaminating themselves somehow, right? So you got to be super careful when you're taking off your protective gear. So, but you can't go in the hospital and do that because the hospital's full of COVID. So here I am in the parking lot of my hospital at midnight, stripping down to my underwear, wondering what the guys on the security cameras are thinking as I'm double bagging all my clothes, in garbage bags, and then putting on clean clothes for the drive home. So it was a life altering experience, to do that. And once things slowed down by July in Chicago, I was able to kind of come off the front line, and we kind of closed up the tents and stuff, and we were able to come to some kind of balance. And so then it became this new enterprise, which was, what do we do with all these people that got COVID and they're not okay anymore? these people with so-called long COVID or what we call PASC, the post-acute sequelae of COVID. And this is a lot of athletes. These are people who, I've seen athletes who were, 15-minute 5K runners, 16-minute 5K runners that couldn't break 30 minutes anymore because of what this virus had done to them. And so my focus very much changed from kind of the acute, how do we make these people not die in front of us, to how are we going to try to help people return to their former level of function. And sadly, for some people, that hasn't been possible. And for some of them it has. That's really what I'm working on nowadays is, in the physiology lab, probably for every quote unquote healthy athlete that I test or something, I'm testing 3 or 4 people that had COVID and are now completely deconditioned and don't know what's wrong with them. And so we try to answer that question from a physiological standpoint and see how can we intervene to help those people.
Wow. Yeah. Well, gosh, oh, man. So are some of these people who, they caught it in the initial rush and then they're still year and a half on, they're still hurting?
Yeah. Because they kind of fall into a few different bins. There are the people who suffered some kind of, for example, heart damage. There are people who suffered some kind of lung damage, which may be one of the larger groups. And then there's the people with this kind of post-viral fatigue, plus or minus some shortness of breath, plus or minus strange pains that we can't explain. That kind of becomes the largest group. And so the question is, how do we intervene to help these people? Because the usual stuff doesn't work. It appears that a lot of the lung damage that occurs sort of at the down in the alveoli, the very smallest air pockets of the lungs, or in the basement membranes that allow the air to equilibrate with the blood and move gas around so that you can live, you can move oxygen around, for example. And we don't have medications that help that. So a lot of times with these people, you're throwing, they come to me after having a bunch of inhalers thrown at them, which are great for things like asthma, but do zero good in the face of post-COVID lung disease. And so what we've really had to do is develop this kind of post-COVID training program, essentially, where we do pulmonary rehab to strengthen their inspiratory muscles and things so that they can breathe better, and start, exercising them so that we can get them to build up a level of fitness so that their day-to-day life doesn't feel like such a challenge. And so it's this really strange twist on what I already was doing for elite athletes, which was trying to find a way to help these people gain new function and just get them back to where they used to be, right? Versus taking them from where the average person is and making them fast.
I mean, is this, I guess, how much of this is new, right? In terms of like these methods of trying to troubleshoot these things and to try to assess what's going on.
It's real challenging. These things didn't exist before, right? This disease didn't exist before. So we're kind of making it up as we go. So again, much like I talked about with athlete training before, we're having to go back to very first principles, and then build up from that basis, which a lot of doctors are not good at, right? Because doctors are trained in terms of algorithms. I see this on the monitor, this is how I intervene. You have this arrhythmia with your heart, I give you this drug, and so on. Those rules don't always apply when you're dealing with people who have post-COVID, this post-COVID syndrome. So you're having to kind of go back more to the basics of physiology. Okay, this is how long they can tolerate walking at this pace, and this is how long they can tolerate walking at this pace, and make that curve, and say, okay, now how are we going to try to train you so that you can do this a little bit faster than before? And that may mean just making you able to walk to your mailbox or go down to the store to get the newspaper. So there is that part of it. Now, some of these things that we're seeing, we have seen before, right? We have seen people with viral damage to the heart, myocarditis. We do have some ways of working on that. We have seen people who develop postural orthostatic tachycardic syndrome. These are people who, it's called POTS. It's very challenging to treat. These are people who say they change position, they get up out of a chair, or they try to do some exercise, and their heart accelerates out of control, and their blood pressure drops, and they get dizzy, and they feel terrible. So we have ways of intervening with things like that. But this large population in the middle, we're making it up as we go. And that's a challenge.
How much information about these things can be shared and how quickly to get everybody, all the doctors caught up and learning from what's happening in Seattle or New York or Chicago or
Yeah,
Italy,
I mean,
right?
I've given a few, conference talks on this kind of stuff for, what we're trying to do here, or the things that we're seeing and the things we're trying to do. But and someone has, written a sort of first swing at a rehab protocol, that's come out in one of the journals. But again, it's none of this is. It's not like we're doing, controlled studies, right? We're saying that, yeah, we tried this and this seemed to work for this bunch of people, but there's going to need to be in coming years, especially after the Omicron wave and whatever comes next. And this is the part that people don't get, is that, oh, it's mild COVID, or, and this is the way, politicians have always justified not taking the measures in a public health sense that are necessary to stop the pandemic. And now that's going to be impossible. But we are going to have this huge raft of disabled people, millions and millions of people, that we're going to have to take care of, in the coming years. And that's going to be a tremendous burden on the health system, that the health system is totally not prepared for. Omicron has not even really hit Chicago yet. Like, numbers are going up, but we're not getting, destroyed yet. Two of my main hospitals here in Chicago, we've already stopped outpatient surgeries. We already have people boarding in the ER because there's nowhere to send them. The health system is already at the limit. 20% of people have quit healthcare in the last 2 years. We just don't have the manpower, we don't have the facilities, and we don't have the money. So we're in for a bad go of it here. And people are still pretending like things are going to be normal. Like, if you look at England, their numbers are out of control. And that's going to be here in a couple of weeks. And we have not learned from our past mistakes. I hate to be gloom and doom.
No. I mean, I mean, it's been, I mean, so you've been off the front lines since, a year last summer.
Yeah.
Yeah. But taking this other tack, the medical system has just been stretched and, it feels like, it's really strange because I can stay here in my cabiny office and do my work talking to people and editing stories, right? And I can be isolated, right? But if you're in the medical system,
right,
or you're in service, or you're driving a bus, or you're doing any number of different things, you can't, it sounds like if you've lasted so far, the Omicron's going to get you, is what it sounds like.
It's totally possible because it appears to be much more transmissible. And we still, cling to this fiction of, oh, just wash your hands and disinfect surfaces. You need to clean the air. The virus is airborne, period. Omicron is as infectious as measles. So you need an N95 mask to protect yourself. Do paper masks, provide some element of protection and possibly reduce the amount of virus that you're exposed to, which could make the difference between you living and dying? Yeah, they do. But do they fully protect you? Of course not. I've been wearing an N95 mask. I bought 3 or 4 cases of them, and I wear them everywhere. When I go to the supermarket, when I get gas, when I'm in the office, totally. It never comes off, and my people do the same. And that's how we've kept it out of my department, is that we've all been super, super cautious. Now, the vaccines aren't particularly effective against Omicron. And so, we're going to need to do some different things. It appears now that at 90 days post booster, you have about 75% protection against severe disease, which, okay, so good. But still, a small percentage of a big number is still a really big number. And so you're going to see a lot of people get really sick because they're not going to get vaccinated. And we even if everyone in the country was willing to be vaccinated, we can't do it in time. So in my estimation, the thing to do would be to literally try and strap an N95 on anyone in this country that's willing to wear one. Is that going to happen? No, it's not going to happen. We don't have the political will, and that's unfortunate. One of my friends is an ID doctor, said this, which is a horrible thing to say, but there's an element of truth to it. He was like, the problem is that COVID doesn't kill enough people. At this point, we all know somebody who died. But if it killed people the way Ebola killed people, we would have had a much different reaction to it as a world. I was in there one day when we had to intubate somebody, and she was crashing, and we're trying to get a tube into her. We are pouring sedation into this woman, but she's so young and strong that it's like it was really difficult to sedate her. So now you're trying to get a tube into someone who's basically drowning in their own fluids. turning blue and thrashing. I mean, I'm going to take that with me to my grave. And if more people saw that, like, this pandemic response might have been a lot different. Because what I did see was, I come out of the tent one day, like one of my nurses, like, Doc, you got to come out here. There's this guy who's crawling through the bushes around the ER with his cell phone camera, trying to see through the windows. And I look at this guy and I'm like, can I help you? He's like, I'm here to show the truth that there's no patients in this hospital. And I'm like, there's no one in this waiting room. I said, you're right. They're all on ventilators in back. He's like, I bet you there's no patients in that tent. I said, you want to come in? And he says, well, you're going to give me a mask? I said, I thought you said there were no patients in here. Why do you need a mask? And they start screaming and swearing and, throwing a tantrum, so we call the cops.
Yeah, it's a lot of problems wrapped together, I guess. Math being one of them, and the concept of how that's what's been really, really hard to see is the lack of grasp of will, like you're saying, to go from I can protect myself and others, and we need to work together, right? Like that's been the hardest part.
Right. I mean, that's kind of the sad part about it, is that this has laid bare these kind of fractures in our society. And part of that is a lack of education, right? Like we've been tearing down the education system and tearing down teachers for decades now. There's that great graphic that goes around the internet that shows how politicians look at exponential. And so you see the curve rising and how, now it's exponential because the curve is really steep. Whereas scientists looks at that curve from the beginning and says, yep, it's exponential here and here and here, the whole way up that curve. And if you had done something about it when it was down here, we wouldn't be in the situation that we're in, right? The answer last summer, when you're getting better numbers, is not to take masks off everybody. Because what did you do except turn that curve right around and start going in the other direction again? And it took a little while to get rolling, but it got rolling, didn't it? Because we're still in the midst of the Delta wave, right? Omicron's just getting here. In a couple of weeks it'll be dominant, but it's just getting here. We're still dealing with Delta.
Well, so what does your long COVID treatment project look like for the next, I don't know, for how you see it going, as the winter and spring roll on?
Yeah, I think part of the question is going to be if we can, because typically the way it works is, people get referred in, they see pulmonology or whomever, and they end up coming to see me, and I do all this physiological testing on them. I think the question is going to be whether we need to pause that in light of Omicron, because it'll just be too hazardous to have somebody exercising in a laboratory with a bunch of other people around. We do test everyone before they get PCR tested before they come in, but that takes 48 hours. So there's a small window there. In the laboratory, we put special filters on the machines that are basically N95, and so they'll catch what these people are letting loose. But you have to take off masks to switch things and switch hoses and things like that. So there's a risk of exposure there. And that's always the question: is what risk are you going to take for what benefit? And there's no good guidance on this because as a world, not just as a country, we haven't done the things that are necessary to make things safe. You need high level ventilation to make sure that you're not spreading COVID around. You need HEPA filtration. You need people in N95 masks and so on. And yet we still have the World Health Organization minimizing the effect of airborne transmission. It's absurd on its face. Why are we playing this game? I don't fully understand it.
The level of frustration that you feel with that, does that alter your motivation for being in medicine or training or where you want to put your time and your focus?
Yeah, I mean, that's a great question. I've struggled with that since the beginning of the pandemic. I know all of us have. In fact, right at the beginning, one of the reasons, one of my partners in the sports medicine practice and I stepped up to go to the front line was that right at the beginning, many of my colleagues refused. Nope, I'm not getting paid enough to do that. Nope, I didn't sign up for that. Nope, not doing it. I have kids, I'm not taking a risk, which I mean, to a level I understand and to a level horrifies me, because your Hippocratic oath did not come with a get out of jail free card for a pandemic, right? You're a physician, you have a responsibility to the world. So that really kind of grossed me out, to be honest with you. And that alone was enough to make me want to say, you know what, like, this isn't for me. So there was definitely that thing that I struggled with, and I continue to struggle with the fact that my health system can do everything it can to try to protect us, give us protective gear and all that kind of stuff, but the rest of society is not willing to do those things, you know. And so you start feeling like, and I understand why so many physicians and so many nurses and respiratory technicians are burning out, is because I'm here trying to save your life, and you won't do the bare minimum of putting on a mask or not going out to eat or whatever it takes to try to slow this down. Why am I risking my life again? Because I have friends. I have 3 friends that were killed by this. So it's personal for me, and at some point there is an element of self-preservation that kicks into your thinking. And it's like, yeah, I'm doing the right thing. But should I keep doing the right thing? Or do I need to start worrying about myself? Every physician has thought about that in the last 2 years. And anyone who claims they haven't is lying. And all of us have different answers. I'm still in the game. I know guys who aren't.
Well, when it's part of your identity to help people, where do you go with that tension?
Yeah, that's a great question. I spent a lot of time playing my guitars, playing my drums. I try to exercise. And I try to remember what got me into it in the first place. Like I said, I was a volunteer firefighter. And I remember being a kid. I was probably 17 or 18 years old. And my dad was the chief engineer. He drove the fire truck for 40 years until he retired. But we were washing the truck for a parade or something, I guess. And one of he's the town dentist too. When I was a little kid, he would like leave people in the chair to go drive the fire truck to go put out a fire, which I thought was always really cool. So we're watching this truck for a parade, and one of his patients walked by, and he's like, "What are you doing this for? This is dangerous." This guy was from New York City, like they had paid fire department. He's like, "What are you guys doing this for?" And my father just looked at him and he goes, "If your house was on fire, don't you want someone to come?" And he says, "Well, yeah." And he says, "Well, then maybe you should think about joining us. We'd be happy to have you." And so I guess it's just the way I was raised, which is that, if you can help, you got to help. Because if for no other reason, that when I catch this, I'm going to want someone to help me. Because if everyone pulls this, oh, it's not my problem, then where do we end up as a society or as a world? We see the way society has become more and more selfish and more self-centered. And what's that doing to us? As just human beings, what kind of pressure is that on us? And then, if you're not willing to be one of the people that tries to be part of the solution, then you don't deserve to complain. So for me, I guess that's the way I look at it, is that I still got to be able to look at myself in the mirror. So we keep on keeping on for as long as we can.
Wow. Yeah. Well, I'm not sure I can ask you another question that would get a better answer than that. So I might let you go. And is there anything else you want to say about training or treating COVID or any? Yeah.
Well, I think what all these problems have in common is that they're solvable, right? You just have to have the willingness to do it. And you have to have the willingness to be strictly honest with yourself, right? In terms of your training, in terms of whatever. Like humans like the nice new shiny thing, oh, there's this new supplement. Oh, there's this new whatever that's going to help in some way. And we saw it with COVID. Oh, I'm going to take ivermectin. I'm going to do all this and that. It's like, look, it's like we know what stops COVID. It's masking and ventilation and and to a lesser extent, washing your hands and behaving better, right? We know what works in terms of making you a better athlete, right? You got to train, you got to sleep, and you got to eat right. And none of the things I just mentioned are glamorous, right? It's all just the hard work. So if you're willing to be honest about that, and you're willing to take those steps, you know, you can make huge differences in your health, and then right now in the public health of the world. Um, it's just that you got to have the willpower to do it. Um, and I guess maybe as a coach and as a doctor, that's my most important job, is motivating people to do the right thing. That's what brought me to sports medicine, really, is that, you know, when I was doing a lot of primary care early in my career, I can't tell you how many times I saw someone with, like, you know, bad lung disease who was like, yeah, but doc, when do I really have to quit smoking? Right. And you're like, oh man, right? You didn't hear a word I just said. Um, you know, versus when I started dealing with athletes and things, um, or where they were injured and they really wanted to get back to their sport, you know, and sometimes it required a come to Jesus talk, but very often they're willing to go along with my program if they thought it was going to get them healthy again and get them back to training. So I guess, you know, in sports medicine, oftentimes you're dealing with like a self-motivated population, which is helpful. And so I guess part of what I try to do is bring that motivation to the widest bunch of people I can. You know, whether it's a little old lady with arthritis in her knees, or it's some, you know, 15-year-old kid who's short of breath when he's, you know, trying to swim with his team. And that's it. At the end of the day, that's all we can do, right? Is you're asking people to change and to try to take them on that journey.
Nice, nice. Well, Phil, this has been fantastic and really enlightening. Thank you so much.
Thanks for having me, Chris. It was a pleasure.
This is just the beginning. We've already have several other great guests lined up. Hope you enjoyed this conversation. If you missed the first round with Phil, check that out too, please. We hope you'll join us for more Inside Science conversations. Please like and subscribe, and keep an eye out, because we're going to have more great chats with really interesting scientists. Hope you like them.